طيب بسم الله الرحمن الرحيم. Ladies and gentlemen, teachers and colleagues, السلام عليكم ورحمة الله وبركاته. Speaking Dr. Taysir Kashif, Director of Al-Tabbab Advanced Training Center. I would like to thank all of you for being with us tonight at ATC Hospitality and wish you a good time. Special thanks to Dr. Abdul Mulim Abdul Rahman for his coordination and his estimated efforts, which is the reason after Allah to hold this session. Thanks to the ATC family and Professor Imad Salah, the spiritual father of the ATC, Dr. Hafiz Umar, and all the board members. I would like also to thank ATC Secretary Ms. Azza Imad and IT Engineer Ms. Rayan Banda. As we know that the main cause of hospital visits in emergencies is emergency cases. So the emergency care is an important part of the healthcare system. In an attempt to develop this system, must therefore go through and focus primarily on the emergency care. What is the role of emergency care in the healthcare system, especially in low-resource settings? And what are the steps undertaken so far to make emergency care a priority? And are there any plans to improve it throughout Sudan? Many questions. Tonight we are honored by Professor Wallis, Needs and Plans for Emergency Care System Improvement in Sudan. Professor Wallis graduated from University of Edinburgh and is the head of emergency medicine for the Western Cape government. Professor and head of the Division of Emergency Medicine at the University of Cape Town and Stellenbosch University, the founding president of the African Federation for Emergency Medicine. Ladies and gentlemen, please make sure to mute your mics. If you have any questions or comments, please feel free to raise your hand. Hope you all enjoy. Professor Wallis, thank you for your time. Your ground, sir.
Salam alaikum to everyone. Good evening. Thank
Salam.
you.
Alaikum assalam wa rahmatullah.
Thank you for the invite. It's unfortunate that I can't be with you in person, but I'm very happy to be back in Khartoum for the first time this year with COVID. I was last here in December. It's now my 6th time in Sudan. I'm very happy to be a regular coming now. I'm going to share some slides with you, if I can make the screen work. I hope so. And
Yes.
I'm going to just walk through about the emergency care system and about what we've been doing in Sudan. I'm British originally. I was with the British Navy and I ended up in Cape Town 20 years ago, just after a year in Antarctica. And I decided to stay in Cape Town. And I have been given a very unique opportunity to create emergency care systems. I was in the right place at the right time. So I've worked in about 30 countries, mostly in Africa or the Middle East, but all low or middle income countries. So I've been incredibly fortunate to get a lot of experience in helping Ministries of Health and World Health Organization to develop emergency care systems, but also to develop the strategy for emergency care in the region. So I want to just tell you how that's been applied in Sudan and hopefully get your engagement in the developments going forward, because it's a challenging time and I think it's a really important part of the healthcare system in terms of access for patients. And if with the limited resources, if everyone could be working together to a common aim, it would really help the population. So just, I was asked to do maybe 40 minutes, something like that, and then some questions and answers. So I want to run through what is emergency care and why do we promote it? And then some specific information about Sudan and the things that we're doing to try and move things forward. So I don't know how many of you are specialties other than internal medicine, but every 6 seconds somewhere in the world somebody dies of injury. It's every 6 seconds, day after day, and it's the equivalent of a jumbo jet full of people crashing every few minutes. And those injury deaths can largely be prevented. Some of them happen anyway, but a lot of them can be prevented by good emergency care. And it turns out that the same ambulance that treats injury is the same ambulance that treats many other emergencies, and the same emergency unit staff that treats injuries also treats other things, many other things. So I'm sure you all know the Sustainable Development Goals. In those, there are about 150 targets that governments are working towards, and emergency care addresses 10 of them directly, and you can see them on the screen. Most of them are health related, but it also 11 is about healthy cities and 16 is about justice and violence. But the same emergency care system treats all of these different conditions and helps governments to hit their SDG targets. So that is really a global mandate for having emergency care. And the World Bank it's the third edition now. It has this big project called Disease Control Priorities. And its aim is to tell low middle income country ministries of health what is cost effective in terms of care. And for the first time last year, when the third volume came out, it had 2 chapters on emergency care. And we found that over half of the deaths that occur every year in low middle income countries are conditions that can be addressed by emergency care. So it's not half of emergency deaths, it's half of all deaths in low middle income countries. So half of all the deaths in Sudan each year, at least half of them could be impacted by better emergency care. And in light of this, the World Health Organization over the last 10 years or so has had a small number of resolutions aimed at improving emergency care. But with the very strong support of the Ethiopian government and Eswatini government, in 2019, the World Health Assembly passed this resolution, which told all member states, including the Republic of Sudan's ministry, how to set up its emergency care system. And since then, both the Eastern Mediterranean region for WHO and the country office here in Sudan have worked tirelessly with the federal and state ministries to try and put changes in place to improve emergency care in line with this resolution. So this is what the emergency care system looks like. I think if you're, we don't see things like this at medical school. We don't teach our registrars this. It's unusual for doctors to be shown what a system actually looks like. And if you're maybe a cardiologist, it's actually a very complicated system because there's so many different components, outpatient and cath lab and primary care and so on. Emergency care is very simple. We're simple people. There's 3 parts to the emergency care system. There's care that happens at the scene over here on the left-hand side. There's care that happens during transport in the middle. And there's care that happens in a facility, usually a hospital, but not always. So on the scene, someone gets sick or injured, and there's a bystander who somehow or other activates the system through a phone call, and then they're given some advice, hopefully, and then a provider is dispatched to them. And then there's an ambulance that up at the top here has some standardized way of communicating and recording clinical information, and they have clinical protocols, and they have a standardized kit equipment, and they do basic care. But the important thing about this that ministries have been having to redirect on is that there's a driver and there's a clinical provider. It's 2 people in an ambulance, otherwise it's a taxi. If there's only 1 person, it's a taxi. You must be able to provide care in the back of the ambulance. And then when you get to the health facility, there's a handover. There's some simple first steps around assessing how sick the patient is and if they have conditions like COVID. Then there's the emergency unit care. And then for WHO, the initial part of inpatient care, the initial part of ICU or operating theatre can also be considered part of emergency care. The federal ministry in Sudan has decided that the back door of emergency care, as far as they're concerned, is this line here when you leave the emergency unit. So when you're admitted to the ward, it's no longer emergency care. If you're admitted to ICU, it's no longer emergency care. You have an emergency and your care should be provided through an emergency care fund, but the responsibility of the emergency medicine world is in front. It's the emergency unit and forward. But we'll come back to that. The framework is supported by, this is the sort of information that's behind it. So every part of that framework has a lot more to it. So if you look at the green, arrival of the patient at the facility, the first thing is registration and screening, triage and handover. but it tells you in these columns what you need to be able to do that. So what communication technology you need, what products, what information and research, what sort of human resources. So everything you need to set up your system is contained in the supporting documents to that simple one-page diagram. And what happens when we go around the world assessing the emergency care systems, we've done this now in about 50 countries, mostly lower middle income, but some high income countries as well. If you look at scene-based care, we see over and over again that there's no laws in most countries to protect bystanders. So if someone stops to help and the patient dies, they go to jail. Somehow they're responsible, or they have a financial responsibility. Most places don't have a phone number that you can call, or they have many phone numbers and it's impossible to know which one to call. They don't centrally coordinate dispatch of ambulances. When you look at the ambulances, almost nowhere has standardized standards and protocols or certification of ambulance staff. Very few ambulances for the needs of the population. And when you get to a hospital, handover happens in a very random way. Often the ambulance will just drop the patient with no handover at all. Care is delivered however each individual clinician chooses to deliver that care. Almost nobody has a formal triage system. And deeper into the emergency unit, many smaller hospitals don't do any, they just say, you're medical, you're surgical, you're orthopedic, and that's it. And they go off to the inpatient teams. Or the emergency units are staffed by doctors and nurses who only spend maybe a month there or 3 months there, and then they move back into the wards. So you never build up the experienced staff that you need. And the resuscitation is a big problem at most district hospitals. So we know that from doing these, what's called an EXA, Emergency Care System Assessment. It's a standardized tool from WHO that takes form of a survey nationally and also a face-to-face 2-day meeting for 50 to 100 stakeholders, the key stakeholders in the country. And it looks at these areas, how the system is organized and governed and financed, what you do with quality improvement and data, and then the clinical care component of emergency care. And we did this in 2018 in Sudan. We had about 90 people from all different aspects of life in Sudan complete the survey. We analyze the results, and then over 2 days we present the results, and we say, for this question about, let's say we have a question about triage. Some of you said there's a very good triage system. Most of you said there isn't any triage system. And then we discuss it and we agree there must be an answer. There either is a good system or there isn't. And we discuss it and we find out why people say yes or no. And we agree a consensus answer. And the main things we found in Sudan, and I'm sure this won't be new to any of you, that the ambulance services do not join up at all with the hospital emergency units. They operate very separately. There's almost no data on what's seen in either the ambulance services or the emergency units. We don't know what emergency care is like in the country at all. Every hospital and every ambulance service uses its own clinical chart. So sometimes they use blank paper, sometimes they've designed their own emergency department chart. There's all sorts of variability in training and certification of staff in emergency care, and there's definitely no money, and staff get attacked regularly. And there's more specific things around the quality and coordination of first aid courses, access to emergency units in the country, and even in central Khartoum, it's very challenging. We know that emergency units just close their doors often. Lack of a triage system. And in fact, we've been working with 12 hospitals and only 4 of them had some sort of triage system, but all 4 had a different triage system. So common problems. Based on that, we ask the participants to tell us what do they need to do in each of these areas. And they come up with 53 action priorities. And then we rank them on how likely are these things to work if we try and do them. Are they expensive or cheap? Are they fast to do or take a long time? Will the politicians support it or not? And from that, we identified 14 top priorities that I'm going to just run through quickly. We then took those 14 priorities and we had another face-to-face meeting of 50 people for 2 days. And we took for each priority and we worked out all the details of how we implement it. How do we do what you said you want to do? And who's going to be responsible for it? And where does the money come from? So we had 4 of those around how the system is organized and funded, 4 of them around pre-hospital care, 3 around hospital-based care, and 3 around data and quality improvement. And the top priority, the first step that we have to do was to establish an agency in the Ministry of Health. And that's partly what I'm doing here right now. So I had meetings yesterday with the task team, and I'm meeting the minister tomorrow, Dr. Osama. He's fully on board with this. We found a person to lead this, and we're establishing the Emergency Care Agency in the National Ministry, the Federal Ministry of Health, and a similar system in Khartoum State is a first, and then we'll ask other states to follow. In the Federal Ministry, it will be a unit with a team, and in states, it will really just be one person, I'm sure. But that ministry will be supported by an Emergency Medicine Council with representation from all the directorates in the ministry, from different, like the Treasury or the Communications Ministry or Defense, multiple different stakeholders, physicians, surgeons, so a wide group of people, and their job will be to guide the strategy of this agency. And the agency's job is to implement the 14 action priorities from the roadmap. So the first thing that we needed to do, we started doing it in 2018, and there was the change of government. We started doing it again late last year, and then there was COVID. So, but now the WHO country office head is completely behind this and has made it a priority. The minister in the federal ministry has made it one of his top priorities. And the state minister for Khartoum has made it a top priority as well. And then the 2 directors of curative at those 2 ministries are also making it a top priority. So we're ready to go, and we have a person who's nominated and has accepted the position. And inshallah, still this year, we'll have that person in post, and we'll have an agency driving emergency care from the federal ministry. And these are the things that they need to do. That is, we'll skip that one, but these are the other 13 action priorities. So the action priorities are written at the top. I just wanted to show you the tables that go with them, that show you the level of detail we went into, which is what are the objectives, what steps do you need to take, what is the timeline to do it, and how do you know that it's been done and that you can continue to monitor it. So please don't pay attention to the tables. Obviously, they're still from 2020. We've spent several days this week updating them with new timelines. But the first activity here around governance is to update the laws and the regulatory framework. So we have norms and standards. We have obligations from hospitals to treat patients. We have obligations from ministries to provide emergency care funding and things like that. We recognize the need to secure more money for emergency care from somewhere. So this agency now at the Ministry of Health, is one of their jobs will be to find new ways of generating money to pay for emergency care. And then under this action priority, it'll be to make sure there is an adequate budget going to the hospitals and to the ambulance services. So those 2 are not easy things to do. Obviously, they're going to take months, if not years, to achieve. So they are long-term, but very high priority. Everyone at these meetings has said, if we don't have the money, we won't do what we want to do. It's not possible. So while it's a very hard thing to do and it takes a long time, these stayed in as the priorities. This one is about having a national registry, an electronic registry that captures key indicators and data about patients coming through the emergency care system. There is a WHO system that already exists. I'll show you it shortly. And this is very quick to put in place. It works on the district health information system that's already in place. So our plan is just to pilot this, make sure that it works well in Sudan, and then we roll this out across the country. This is something that's a bit closer to home for many of you, I'm sure. Both in the ambulance service, but mostly in hospital, we want to have a standardized clinical chart. So we have a WHO clinical chart that has been developed that has all of the right indicators to link to the registry. And we want hospitals to pilot this. Again, we'll pilot at 3 or 4 sites, and we'll get some specific feedback and research on it to make sure they work. And then we'll roll them out across the country. And this, it not only allows to have quality improvement, but when we've piloted these and researched these charts in countries like Tanzania, without doing anything else in the emergency unit, if you introduce these charts, we cut mortality in resuscitation cases by about 50%, because the chart, the way you have to fill in the chart is airway, breathing, circulation, disability. So even without putting someone on an ACLS course or an ATLS course, they learn, after filling in a few charts, they learn to think airway, breathing, circulation. Then they manage the patients, airway, breathing, circulation, and then patients survive. We've already started training staff in quality improvement so that they know how to do M&M meetings properly, to learn from them, to implement change, how to do a quality improvement project in their unit, how to effect change in their unit, and bring the staff and the patients along with them so that they don't resist and they engage properly. This is a very difficult one. This is to have a single ambulance contact number like 112 or 999. This is not really within the health remit. It's a priority for the ministry because it's about access to care, but the decision-making lies with the Ministry of Defense and the Communications Ministry and so on. So this is going to be quite hard to implement. And this one is obviously critical, but is going to be very expensive to implement, which is to have an ambulance service in each state. So we're going to start with 1 state or 2, and we're going to work through over a couple of years and pilot it. There is a donation of 60 ambulances currently here, and another 60 come in, I think, from Saudi Arabia this time. So from those ambulances, we should have enough to pilot in a couple of states a decent coverage of an ambulance service. We train some ambulance staff. We give them clinical protocols, we give them equipment, and then we measure the impact on patients. Do patients survive? What's patient satisfaction like? What's staff retention like? We have to ask these questions before we spend millions and millions on ambulance services that might not work. While we're developing the ambulance service where we have a paramedic of some type, they don't have to be trained at very high level, but we have someone in an ambulance in uniform who's paid by the ministry. That's a formal ambulance service. While we're doing that, there's a very well-established system of training the community to be like an ambulance service for you, where you can get the community to respond and provide basic first aid to patients. So we want to roll that out in other states where we're not piloting the formal ambulance service, and we see what the impact of this is also. We know from multiple studies that if you use this system combined with some paramedics in ambulances, it costs about $7 to avert 1 year, to save 1 year of life. So to avert 1 year of life lost. $7, I know most people don't know whether that's good value or not. To do exactly the same, to avert 1 year of life lost with antiretrovirals for HIV is $950. So this is 5% of the price of antiretrovirals, and nobody ever questions whether we should provide antiretrovirals. It's part of the essential package of care. So this is very cheap and very good value. We recognize that once patients get to hospital, there's a big problem moving them between hospitals. Hospitals refuse to take the patients, they close their doors, and so we want to fix that problem. We want to have a properly accountable interfacility transfer system where doctors only move patients when they're accepted, and that you can't refuse if you have the capacity to manage the patient, and that we have a central coordination of that so we know where the capacity is. Because at the moment we have an ambulance goes to one hospital and then they go to another and another and another, and the patient is in the back of that ambulance and has a very bad outcome. We want to introduce a lot of clinical checklists and protocols and guidelines. We know that they can make a big difference. A triage system for all emergency units and for the ambulance service, and then disaster plans. I'm not expecting you to remember all of this. This is a lot, but it's a very wide range of things that we're doing both outside the hospital and in the hospital, and with ministry and frontline providers and everything in between. So when we've done these assessments with WHO in different countries, and we find that countries want the same things, the action priorities that we have there, either the 53 or the 14, we see common themes come up all the time. There's policy gaps, there's triage and clinical protocol gaps, people are not trained to provide emergency care, they don't collect data and they don't have quality improvement, and they have very poor pre-hospital systems. So we've been working with WHO headquarters and have developed a set of legislation and regulation policies that countries can take and just adapt locally, a triage tool for pre-hospital and hospitals, a basic provider training course, a registry and standardized charts, and then a whole series of tools for ambulance services. We've been doing an improvement project in the Republic here for nearly 3 years now. I've been coming backwards and forwards. And as I said, the change of government and then COVID have really disrupted that. But we had 12 hospitals. We had 8 in Khartoum in the city, and then Al Fasher, Al Damar, El Obeid, and North Kordofan. And we're introducing all of these things. So we trained about 400 people on the basic emergency care course. We introduced the triage tools, we introduced checklists. And then of course, we stopped for a year or however long because of the problems. And then the staff have all changed and then we have to start all over again. So that's what we're trying to plan now, to start all over again with the 12 hospitals. We now have some new money from headquarters to do that and to measure the impact of those changes. And they're all bundled together into this one toolkit called Essential Resources for Emergency Care. So that is things like the assessment. So the national assessment is the EXA, and then there's a hospital level assessment where you can work out at an individual hospital what the gaps are in your emergency care. And we've done that at nearly 20 hospitals now in Sudan. And then there's a whole bunch of tools I'll show you for clinical care, and then there's some training tools as well. So in addition to the national assessment, there's this hospital assessment, and we've done it at Bari and Omdurman and Ibrahim Malik, and 12 hospitals in our program, and then we've been doing it at other hospitals in another project with WHO. There's a lot of things around ambulances, and it's not the right audience for ambulances, but basically if you want to set up an ambulance service, we can give just a bundle of resources and say, there you go, you make those appropriate for your local setting, just fill in the blanks and you're ready to go. Everything from training ambulance providers, equipment lists, how to maintain your fleet of vehicles, how to train drivers, everything you need. This is really interesting. We have a checklist for the resuscitation room for trauma and one for non-trauma patients. And just like the standardized notes, we introduced this trauma checklist in 10 hospitals across 5 countries. And we measured trauma mortality beforehand and afterwards for months. And we made no other changes. All we did was introduce this checklist. And every time there's a trauma resuscitation, the doctors have to complete this checklist before they leave the patient. And this checklist by itself, with nothing else, cut 50% mortality, 50% of deaths avoided just by using a checklist, because doctors forget to do things and a checklist reminds you to do it. Just like a pilot in a plane reminds you to check all of the buttons and all of the lights. We're rolling out this triage tool into the pilot hospitals over the next few months, and we'll collect data on that. So we want every patient who comes into the emergency unit to be triaged, and then they're seen in the priority order, not in the order in which they arrive in the unit. Because if you do that, people die in the waiting room. The registry I've spoken a little bit about, that is ready to roll out. Also, we'll pilot that here. And then this is just one page of the standardized charts. We have a chart for trauma and a chart for non-trauma. And it just, as I said, it takes you through the airway, breathing, circulation approach to patients. And you don't really need to train people if you use this. They start to think in that way just by completing that form. The basic emergency care course is really one of the main things that I really want to push here in the country, that we, through medical school and nursing school, there's very little focused teaching on emergency care. The cardiologist might teach you about managing an MI, or the anesthetist might teach you how to intubate, but how do you assess a sick patient who is unconscious or has difficulty breathing or is shocked or some circulatory problem? This takes people who see emergencies but have no formal training in emergencies through a 4-day course, and again, makes a massive difference. I'm going to show you some data at the end. Makes a massive difference to outcome. We trained several hundred people, but then again, we stopped, and we lost a lot of those people from the system. So we start this again now. And we've also put together a course on how to actually manage your emergency unit. Supply chain management, quality improvement, patient safety, design of the unit, patient flow, all these sort of things. And we've taught that a few times. These are hospitals in Uganda and Tanzania, where this is where a lot of this material came from. We developed it and we tried it there. We did things like we made an emergency trolley where there was none. So we put all of the resuscitation things in one place with the checklists, and we labeled it clearly. We introduced a register in the middle here. We introduced an area with 2 beds where the sickest patients in the unit went. Before then, they went anywhere, but then we put a red sticker on the wall so that all the doctors and nurses knew this is where the sick patients are. And we introduced simple things like a triage tool with brightly colored cards. So this doesn't cost money. This is some paper and some pens and some reorganizational resources that are already there. We collected a year of data on the mortality of postpartum hemorrhage, road traffic injury, diarrhea in children, asthma, and pneumonia. And then we implemented triage, the basic emergency care course, the clinical checklists, and we set up a resuscitation area. And it cost, to do all of that, about $3,000. And then we measured mortality again, and it cut mortality by 70%, 70%, just by doing these very simple things. For $3,000, we saved hundreds of lives. So that's all the WHO materials. There's also an organization that I helped to found called the African Federation for Emergency Medicine. Many of the resources that we have complement perfectly to WHO resources. So as we go forward in Sudan now to implement those 14 action priorities, and we do the 12 hospital pilots at the same time, we're going to be introducing all of the things you've seen already, in addition to some of the other resources that the Federation has, like a list of essential medicines that must be in the emergency unit, a list of essential equipment that must be there. So a district level hospital has to have this type of equipment, laryngoscope, for instance, and a referral hospital should have a ultrasound machine and somebody who's trained to use it, for instance. And we're going to be rolling those out over the next year to 2 years through these 12 hospitals and through the agency in the Federal Ministry of Health. Our intention is to measure mortality the same way that we've measured it now. So we plan to start in the next month or so collecting baseline data. What does the mortality look like now before we introduce any change? The problems that we face, that the reason I'm so excited to talk to you as a group of physician leaders is it is incredibly hard to do these changes when the senior staff leave and go overseas, and when the junior staff don't want to work in the emergency unit because it's not a good place to work. They don't get paid to work there. They get pulled out of there very quickly. Or if they're a medicine or surgical registrar, for instance, they get sent there, but they're not trained. They don't know what to do. They do a day there, and then 2 weeks later, they do a day there, and then they only do a day there when they're on call, and they feel unsupported. So it would be great if for the 12 hospitals where we're doing this work, and I can offline, I can share with you which they are. If any of your network work in those hospitals, we really need the support of the inpatient teams to get particularly their junior doctors, to go along with this and help support it, because we know for a fact that the changes that we're making that don't cost much money save lives in a very, very dramatic way. I will leave it there. Thank you very much. I'm happy to answer any questions or any discussion that you would like to have.
Thank you, Prof. Wallis. Actually interesting. I can see that the session started by root cause analysis, by identifying the problems in the same triage facility, and the problems mainly noted in communication, triage, transport, transfer, handover. And then it took the color of, I think Prof. Ahmad may highlight this point, color of system thinking, because we start to focus on objectives. And you identify the 14 action priorities to establish the most important is to establish a lead agency. Actually, what you did, thankfully, is to identify the higher leverage point, I think, is training. Because training, I think, is a high leverage point by putting also the order sets and triage system, checklist, etc. Then the facilities may come. Of course, they may go parallel, but I think facilities may come after training because you have to train, then you have to provide the facilities. Regarding order set, actually, we in Tababa as partners in healthcare system improvement, we developed our first edition of Tababa order sets books. Prof. Ahmad, you may have a comment.
All right. Thank you much, Professor Wallis. We were really very grateful for this really very rich talk. Really, I'm actually very impressed by the depths of the depths of work and the depths of actually thinking is taken there. I'm actually not surprised. I think I should really congratulate you on an unbelievably enormous work. Really, it's great work. It's a lot of work and effort done put into that. And we actually teach at Tababa the system thinking, and I think you've actually portrayed all the elements of system thinking and leverage points, and in the session. As a matter of fact, I was having a list of questions, but you've actually managed to answer loads of questions they had, because you've actually covered all the aspects from a top-down approach to a bottom-up approach, and creation of a body to oversee all these important interventions, right? So I think we at Tababa actually are working also in that emergency part, and we have actually tried, obviously, focusing on a small part, because we don't have all the facilities or resources, but we tried to come up with at least some order sets for the common emergencies in Sudan, and at times we tried to actually improvise and make use of whatever available resources. One of the things we have actually put in our order sets and in our teaching material is, for example, in bronchial asthma, is using a water bottle as a spacer for actually treating acute asthma, and all the studies that came initially from South Africa about the effectiveness of a water bottle in treating acute asthma. And so we tried, whenever we've actually in our training sessions, emergency medicine, so forth, to improvise and use whichever available material in management, in evidence-based management. But I really would like to thank you once more and really congratulate you on an unbelievable and enormous effort. And I think we are really very indebted, for your input, really, and for working very hard to help us actually improve emergency services in Sudan.
Thank you so much. If I may just be allowed to make two comments, I certainly don't want to take the time, but I appreciate those very kind words. I think the first comment is that one of the things that became very clear to me very early after moving to Cape Town was that the stuff that we're taught in high-income countries is just, okay, the underlying pathophysiology may be the same, but how you can investigate and manage the patients is not the same. and we have to make our own solutions for our own patients. And like you say, the water bottle is one perfect example. And that's one thing the African Federation's done. The American textbooks of emergency medicine are so irrelevant to our practice. So we have our own textbook. It's like a 1,500 page textbook. And I usually bring with me, we have, I think I see Dr. Osama is on the list. I think he's distributed a few of those before. But they have African solutions to the problems that we see. And then my main comment is your words are very kind, and I certainly appreciate them, but I am not taking them for me. I'm taking them back to the team, because I don't want anyone on this call to be under any impression that I've done this work. I am the face of the work, for sure. I'm the international consultant who, for reasons that are beyond me, people stop and listen to. But from the minister to the directors of the curative units, to the leads of the emergency units, to the team at WHO and in the ministry, and the clinicians at the front line, we wouldn't have achieved anything we've done without the really hard work of all those people. Particularly, we had a small group of national consultants and registrars helping us. And although we've had a lot of turnover, I see the director of curative is actually on the, I think maybe he's just dropped off now, but I saw him, no, I still see him on the call. If it wasn't for his championing what's going on at the moment, we wouldn't be moving forward. And it would be inappropriate for me to take the credit for the hard work of the people here on the ground in Sudan. I come and go and I support remotely, but the work is done here and the change will be made here. But anyway, thank you for the opportunity. It's been a real pleasure to be with you this evening.
Thank you, Wallis. If anyone wants to comment on a question I see here, so of our friends from Federal Ministry of Health, Medical Insurance, so the door is open for comments, questions, maybe. Okay, anyone has a question or comment? Dr. Haitham. Yes, welcome, Dr. Haitham. Dr. Haitham from Federal Ministry of Health. You are welcome, Dr. Haitham.
Assalamu alaikum. Thanks, Imad. Thanks, Professor Lee, for this great talk and your great role in establishing and contributing in establishment of this system in Sudan. Just I would like to hear from you the expected role of the multidisciplinary team expected to be part of this emergency care system. We know that it is not just a responsibility of the medical doctors. We expect to the ambulance drivers, the healthcare workers, the medical assistants, particularly if this program will be national and will be implemented in rural areas, and there may be not enough medical doctors to run such service. In such situations with this limited numbers of medical doctors who are maybe trained doctors in the program, what is your advice in this area and the expected role of this multidisciplinary team and healthcare workforce in implementing emergency care system in Sudan? Thanks again, Professor Lee.
Thank you for the question. It's a really important fundamental issue that we have to address to make sustainable change. And I think you're with us tomorrow when we do we have a presentation tomorrow morning with a lot of hospital directors. I'm going to show a figure in that it speaks directly to that. And it's my mistake. I should have put it in this talk now. We conceptualize like a pyramid. So at the very top of the pyramid for the emergency care system is the highly trained emergency medicine specialist, like myself, through a residency program. There should be very few of us in the country, and our job should be to lead, advise on strategy and lead teaching and research. I think every time there's an emergency medicine specialist who is seeing a patient by themselves in a low resource setting, it is a waste of that person's training. Because there's such a scarce resource, we need them to manage the system. We need them to improve care for all patients. not for the patient that they're seeing at that time. Because on shift, maybe you see 20 patients, they get good care. But the other 150 patients who came to your unit who were seen by the intern, you know nothing about. So the specialist job is to put in the quality of care and the clinical governance and the regulation and make sure that the staff are well trained and all those sort of things. And then working down, there's the doctors, the registrars and medical officers, and there's the nurses and the, in places that use clinical officers or medical assistants. And there's a bundle of training that they should have, like the basic emergency care course and a skill set. But the overwhelming majority of emergency patients will be seen by those providers. Almost none will be seen by a specialist in emergency medicine. Whether you're talking about a deep rural area in Darfur or you're talking about even in Ibrahim Malik, the specialist should not be the one seeing the patients. The patients are seen by junior doctors and nurses and mid-level providers. And of course, pre-hospital, there's the two groups. There's the ambulance providers who are employed, professional, trained ambulance providers, and then there's the community. And we need to use both. And on the pyramid, the bottom level of the pyramid is the community because there's more of them. So they're the wide base of the pyramid. And we should flood communities with trained first aiders so that when someone gets hit by a car or has chest pain, there's somebody there who knows what to do with a very basic equipment, maybe $1 worth of some gloves and a bandage, something like that. And they can help until the patient can get to a hospital where a nurse can see them or a junior doctor with some basic training. We don't need, and we will never have, highly trained doctors everywhere. Partly because it's too expensive and partly because every time we train a doctor, well, they go off overseas where someone else can pay them a higher salary. And it will be like that forever, or certainly for the next 50 years. So we must put that out of our minds and think we need, I don't know, we need 200 specialists. So we train 400 because we'll lose half of them. And the other 200 will run the system for us. But we have to focus on attracting and retaining in the units doctors and nurses at a lower level who have the skill and the interest to stay in the unit and provide good patient care. And at the moment, that's our big challenge, I think, here, that we have some specialists for sure. We have nothing pre-hospital, we must work on that. But the doctors and nurses are in the units and mostly not engaged. They are there for free. They're there out of their own goodness, or they've been told to go there by their surgical consultant and they don't want to be there. And we have to change that and get them to invest, make it an attractive option for people. And inshallah, I'd like to work with you, sir, to try and find solutions for that going forward. Thank you.
Thank you, Professor Wallis. We have Dr. Amin. Dr. Amin, welcome.
Thank you, Imad. I have a question for Professor Wallis. I think I speak on, like, for a lot of my colleagues who have left Sudan a long time ago and now have established themselves as consultants, physicians in high-income countries. And I think this is a question that comes on their mind a lot about, because I don't see a lot of us coming back to Sudan and practicing there for at least the foreseeable future. How can we help is my question. We've been disconnected from the practice in Sudan. I mean, for me personally, it's been 11 years since I've left. But we really would like to pay back and take part in whatever possible efforts that we can contribute to. So if you can highlight to us how we can do that, that would be great. Thank you.
Thank you. As someone who left his home country and moved to another country, I am never going to criticize someone who decides to leave. We all have our own personal reasons and needs and family needs and so on. And I moved in the opposite direction to the tide, which is just, I made a lifestyle choice, and it's actually better than living in the UK. But I train registrars and paramedics every year, and I lose 40% of them to the Middle East or to the UK every year. And it's never going to change because they pay a year's salary in 1 month over there. That's how it is. So your question is really important because they will always go. My job is not to try and stop them going. My job is to keep them interested in their home country so that they can continue to contribute. Now, I think the the answer can be very generic if you're talking about how do you help in general as a physician. But if you're talking about specifically for this emergency care improvement, to improve emergency care in Sudan, I can give you a very specific answer. I think if you're looking at a more generic, how do you help? I don't know enough about the other fields of medicine here to advise what the bodies would be. I know there's massive challenges around inappropriate reallocation of funding or misuse of resources and so on. Certainly from the emergency care system point of view, we have discussions that started today, and I'll be taking them to Dr. Haytham tomorrow in the hope that we could establish something like this. But we have, through WHO, we have these very strong programs that the ministry is driving, that WHO is supporting. But we would like to have them funded much more than we've got them funded right now. And so one thing we'd like to do is try and, what I'd like to encourage the ministry to do is set up some well-governed fund that can take donations that go specifically to an emergency care improvement project. If you want to do something that isn't a financial contribution, I would really like to have the big things that we're going to need to do around developing clinical protocols and developing and training people on those protocols and on the courses that we have. We need people to do that. We need trainers. We've trained a bunch of trainers here, but of course half of them have gone overseas already, and the ones who stayed don't have the time always to get off their job, or they need to be paid to be off their job. So if you, for instance, were interested in being back in Sudan 2 weeks a year and you have skills in basic emergency care, you've done the course before, we can train you to be a trainer, you could teach the course. You could teach, in 5 days, you can teach 60 people to be better emergency care providers. So I think there's for emergency care specifically, you can go down the financial resources side, or if you want to help with your knowledge and your skills, then I would very much like to see that go into either this centralized system we're going to set up of developing national protocols and clinical guidelines and adapting international practices to Sudan, so that we have order sets, and if someone comes in with shortness of breath, these are the 5 steps you do for them. So there's a sort of expert process for that, but also teaching people. So it'd be great if you, sorry, I have no idea of your background, but it'd be great to involve anybody who's sitting overseas with that skill set and the enthusiasm in those sort of things.
Right. If I may ask a question, that's all. If maybe Dr. Iman could stop her screen sharing, because we are seeing her telephone. Now, if I may ask just one question, Professor Wallis. You know, you said you've actually been to Sudan 6 times, right? We actually, as Al-Tababa, we've been working for 5 years to improve clinical practice and training in Sudan, right? We've got actually like a structured program, and we focus on personal empowerment and so forth. If I may ask a bit of a complex question, really, where did you find the bottlenecks which actually slowed down, you know, the progress of, you know, improving emergency care services in Sudan? And what would be your advice or suggestions, right? Because for us in Al-Tababa, we've been working on, you know, how to improve the service, and we train people on systems thinking, evidence-based care, and the competency-based training, all about improving the service as a whole. We have our own experience, and obviously we know some of the bottlenecks. But what would you say the bottlenecks which actually hindered, you know, the emergency care service improvements in Sudan, and your suggestions for actually dealing with them?
Okay, really important question. Thank you. I think it's at sort of three different levels. The first is almost a sort of national level, beyond anybody's control. You know, we actually were making really good progress, and then revolution and government change, and that is a many-month reset. It wasn't even a delay. You know, by the time we came out of the other side of that and things settled back down, a lot of the people who were driving in individual hospitals, for instance, had been replaced. So then you have to go back and start all over again. And then COVID obviously it's also a reset. So many people were trained again or brought on board and were enthusiastic and bought in, and then COVID and they've gone. Or then bosses knew, and then they have to start all over again to explain everything and get the buy-in. So that's at a very high level. At a more manageable level where things you can, I mean, they are beyond anyone's control, things that you can control. I think we were anyway going slower than we wanted to, and we see this in many other countries in the region. We go slower if the decision makers in the ministry or in the hospitals, for whatever reason, don't champion it. So it might be that they don't believe in it, that they think it's the wrong thing. But what we found actually quite a lot here in 2018 into early 19 was that people wanted to have some incentive themselves to. So if I get a better emergency unit, it's just going to bring more patients. That's not of any interest to me. My staff are going to work harder. Why do I want to do that? So you have to, that people were holding back on progress because they didn't see the personal incentive for them. It was just going to make their life harder. They were going to have more doctors who were working harder and they were unhappy or whatever it was. And then the final thing that is, it's also solvable, but is a very hard thing to solve, is such a high level of staff turnover. So every time we did a basic emergency care course and trained 50 people, within a month, half of those people were gone. And so we had 50 people in the emergency unit who knew better emergency care. You get a month's good value from that, and then you have 25 new people who've never been trained before, and you're almost back to the start. So we have to solve the turnover problem with, as I mentioned before, somehow recruitment and retention strategies. And I understand the financial challenges of that, and I understand how it's system-wide and how if you do it in the emergency unit but not in orthopedics, then it upsets doctors and it upsets nurses. But at some point you have to decide what's the priority part of the health system for you. And if it happens to be emergency care, then you have to invest in it. And you know, it's a conversation I'll be having with Dr. Hytham tomorrow and with the minister about, I think, the most important part in a country like Sudan, with where the health system is, happens to be the emergency care system, because it's how people access care. They don't have a primary care physician. They access care through the emergency care system.
Right. Thank you very much. I think Dr. Taysir has actually has left us. Anybody wants to just go ahead and ask Professor Wallis a question at all? Because I don't want to ask him myself and then I'll take all the time. Anyone? Right. If no one is asking, I'll just want to comment on your last statement. Actually, we are, this leadership issue, you know, leadership commitment you've actually just raised is fortunately now changing a lot in Sudan. It's a new spirit, and we see young generation and very motivated, enthusiastic people like Dr. Hytham. He just, you know, he's doing a great job in the federal ministry. A comment just for Dr. Amin, who said what would be the contribution of expatriates towards the emergency service. As a matter of fact, they have a lot to offer, and we are glad in At-Tababa that we have a special office for expatriates that could help them, you know, come and join in the effort. And it's all for free. And people could just contact At-Tababa, and we will actually organize everything for them from A to Z with all the important bodies in Sudan, whether it's a Federal Ministry of Health, the you know, Sudan Medical Specialization Board, or even some colleges. So by all means, all these expatriates are welcome, and we offer them actually a free service, and we assist them in all these things, right? If there is no one else wants to comment, I'm going just to thank Professor again. You want to say something, Professor?
Yeah, just a very brief comment. Thank you. You mentioned about the new spirit, and you're all incredibly busy people, and there's only so many hours in a day. And like you, I have too many demands on my time, and there are a lot of countries, including my own, where I should be or could be working. The reason I want to come back to Sudan, the reason I'm so enthusiastic, and the reason I believe in this project completely, despite all of the many challenges and people tell you all the time of all the problems. There is a new spirit. There is so much enthusiasm and really dynamic, smart young people who want to make change. And that's what brings me back. And I think you should all be very encouraged by it. It's very hard to see when you're living in the reality of it every day. But when you come every now and then from the outside, you can really see the change.
Thank you very much. That's a very great comment. Thank you very much for Professor Wallis for the time and for your effort and your team. And we hope, to make use of your, experience in improving our work in Al-Tababa. We are mostly a charity organization, and we actually provide support in training for all healthcare providers. Thanks again to the audience for the time and for joining us in this very lively and very rich meeting. And thanks to our organizers, Dr. Taysir, Dr. Rayan, and Ms. Azza from the Tababa Training Center, right, for all their effort in making this a reality. Thanks again, and hope to see you once more in a very short time, inshallah. Right. Thank you, sir. Thank you all. Bye-bye. Thank you.
Bye-bye.